Good morning, students. You're all welcome to the class. I hope you all rested well. It's obvious. I can see all over you. You're all looking radiant. Today we'll be treating a new topic entirely. We finished the topic on neurological disorders. Now we'll be treating temporomandibular disorders. For you to be able to do justice to temporomandibular disorders, we have to treat the anatomy and the physiology. That means the muscles that are related to the joint. You've all treated through anatomy and physiology. So we're brushing over, talking about the glenoid fossa, the articular eminence, the tubercle shouldn't be strained to you all. And we also will be talking about the muscles that help in elevating the jaw, the muscles that help in depressing the jaw, the muscles that help in protruding the jaw, the muscles that help in retruding the jaw, and also the different disorders of the jaw. And by the end, I'm sure we'll be able to manage any disorder related to the jaw. Thank you. We shall follow the outline below, starting from introduction to anatomy to classification down to conclusion. The introduction. According to the American Academy of Orofacial Pain, TMG disorders are defined as a collective term embracing a number of clinical problems that involve the masticatory muscles, the temporomandibular joint, and associated structures, or even both. Temporomandibular disorders is not just a single condition, it is complex. The anatomy of temporomandibular joint. It is a diarthroded joint lined by fibrocartilage. The anatomy. The temporomandibular joint comprises the condyle of the mandible, the mandibular fossa, the articular disc, the articular eminence or the tubercle, and it has a superior compartment and an anterior compartment that is separated by the articular disc. The anatomy of the temporomandibular joint is shown in this picture. We have the mandibular fossa, the articular disc, the articular tubercle. We can see the superior compartment, the inferior compartment that is divided. They are both divided by the articular disc. The ligaments of the temporomandibular joint are the sphenomandibular ligament, the stylomandibular ligament, and the lateral ligament. The movement of the temporomandibular joint is carried out by muscles, and the muscles are attached to the angle of the mandible, the condyle, and the coronoid. They include muscles that help in elevating the jaw, the muscles that help in depressing, the muscles that help in protruding, retruding, and also in lateral movement. The classification of temporomandibular disorders. We have the temporomandibular joint dysfunction syndrome or myofascial pain. This is the one we see majorly in oral medicine clinic. We have congenital and developmental disorder, and under these are condylar hyperplasia, and condylar aplasia. We have disc displacement, which could be with reduction or without reduction. Degenerative changes. Degenerative changes are the osteoarthritis, and we also have systemic arthritic condition, which is the rheumatoid arthritis. We have ankylosis, intracapsular or extracapsular. Dislocation of the temporomandibular joint, the traumatic injury to the condyle, neoplasm, and drugs. Temporomandibular dysfunction syndrome. As I said earlier, this is what we see majorly in oral medicine clinic. It is characterized by pain around the temporomandibular joint. Sometimes the pain are felt around the jaw, and when you palpate the patient feels pain. It is usually dull and also increases with muscular use. The clinical features include headache, altalgia, and when the patient is properly probed, sometimes we can detect bruising, clenching, excessive chewing of gum, or eating hard food. And all this lead to muscle fatigue.
the muscles they are overworking. As a result, they release neurotransmitters, pain neurotransmitters, and this will be felt by the patient as pain. Myofascial pain dysfunction syndrome. Myositis, this is inflammation of the muscle. The muscle spasm, as we've said, when there is pain, or when they start with muscle spasm, then pain. We have collagen vascular disorders, and under this we have Sjogren's syndrome. In Sjogren's syndrome is an autoimmune disease and autoimmune condition, and it's characterized by xerostomia, and with rheumatoid arthritis. In systemic lupus erythematosus, when the patient is being seen, sometimes you see the malar rash or the butterfly rash, and there is a characteristic positive anti-nuclear antibody, also high erythrocyte sedimentation rate, and a positive rheumatoid arthritis. There is also scleroderma. In this one, there is limited jaw opening with pain when the patient presents. There is as a result of fibrosis. Condylar hyperplasia is non-developmental of the condyle, usually associated with craniofacial abnormalities. Early treatment is indicated to limit the degree of deformity, and this is best done with a costochondrial graft. Condylar hyperplasia may be congenital, and it could be related with other abnormalities. And treatment of the child involves the placement of costochondrial graft as well. In the adult, treatment involves either you shortening of the normal side or lengthening of the and both leads in the long run to an acceptable cosmetic and functional ability. The condylar hyperplasia is an idiopathic disease characterized by a progressive lateral growth of the mandible, and the chin is deviated towards the unaffected side. Presentation is usually in the second decade of life, and recorded findings are usually a normal condyle but an elongated neck. But sometimes we just see that the condyle around that area is, and treatment depends on whether the condyle is to disc displacement. For the disc displacement, we can have with reduction or without reduction. This is positioned anterior and medial to the condyle in closed condition, and palpating the TMJ during a closure, we failing to maintain its normal position. The closing or opening may be normal, but crepitus may be present. With anterior displacement, anterior disc displacement without reduction cannot be reduced. That's what it means. And disc as permanent displacement as permanently displaced anteriorly and with restricted opening. And we have different classification. We have type 1A, type 1B, type 2. For arthritis, we said we have the arthritic degenerative changes and the systemic related, the osteoarthritis and the rheumatoid arthritis. For the degenerative, usually as a result of age, the patient is aging. It could also be trauma, and it could also be secondary from other joint diseases, and it is associated with pain and usually with crepitus. And we can see obvious limitation in mouth opening. Variety of anatomical findings are seen. We can see that the disc is irregular. It could be evaporated. As because of that too, we may see, because of the degenerative changes, we can see osteophytes. For the rheumatoid arthritis, this is usually related with other systemic condition. And in early stage, there are few radiographic changes, but as the disease advances, the joints may space becomes progressively narrow. In the end-stage rheumatoid arthritis of the TMJ, the joint space obliteration results in destruction of an anterior and posterior aspect of the condylar ends. But in juvenile rheumatoid arthritis with TMJ involvement, end-stage disease can result in destruction of the condylar growth plate. Ankylosis of the TMJ. We have intracapsular and extracapsular. And this is as a result of fusion of the condyle, it could be as a result of fusion of the condyle, the disc and fossa. And it could also be classified as fibrous or bony ankylosis. And causes are usually due to trauma with condylar fracture. There could be partial or complete immobility of the jaw. And radiographic findings, irregular articular surface of the condyle and fossa, varying degree of classification. Ankylosis of the TMJ. We have now talking about the extracapsular ankylosis. This one usually involves the coronal process and temporalis muscles. The frequent cause of coronal process enlargement or hyperplasia, and can be related to infection around temporalis muscle. Limitation of opening complete is rare, and on panoramic radiograph can see elongation of coronal process. Dislocation of the temporomandibular joint is caused by mandibular hypermobility, such as yawning when somebody yawns, or eating, or during a dental procedure. Subluxation is a displacement of the condyle which is self-read. Dislocation may be unilateral or bilateral. It is painful and often associated with muscular spasm that is similar to the one in temporomandibular dysfunction syndrome. In more serious condition, when the mandibular condyle translates anteriorly in front of the articular eminence, it is locked. The treatment. Reducing, we can apply what we call a Procoid maneuver. Following reduction, there should be mandibular restriction of the mouth. We need to put an intermaxillary fixation. Posterior dislocation is very rare. Is traumatic injury. Fracture of the coronoid process are uncommon, but fracture of the condyle and subcondyle are common. We do intramandibular fixation when there is dislocation, and after reduction, then you want to keep the mandible from being functional, so you can do what we call in a layman's language wiring of the jaw. Bilateral fracture usually is accompanied in, we see what we call anterior open bite, and in this one you see that the mouth is a bit, the upper and the lower jaw are not closing together, and this will often require open reduction with internal fixation. Neoplating of the TMJ. The most common tumors are the chondroma from the cartilage, osteoma from the bone, and it could be a combination, osteochondroma. Very frequently, malignant tumors such as fibrosarcoma and chondrosarcoma are seen, but they are not frequent. Rarely, fibrodysplasia, giant cell reparative granuloma, and chondroblastoma are seen. They are radio-resistant. Drugs. Some drugs can also cause muscular spasm. By the time the person is chewing excessively, it could now lead to muscular spasm. Such drugs include phenothiazine, an antipsychotic drug. We also have metoclopramide, which has phenothiazine-like properties, can also cause that. Now, in the management, we need to take a proper history. A full medical and drug history should be taken. The sign and symptom might include pain, sometimes swelling, sometimes headache, sometimes hairache. For temporomandibular dysfunction syndrome, crepitus can be heard. For arthritis, no, for temporomandibular dysfunction syndrome, clicking sound may be heard. For the arthritis, then crepitus may be heard. The presence of triggering factors like patients that chew a lot, chewing gum, we can elicit that. And there may be limitation. History of trauma or habitual activities can also be elicited. Physical examination. You have to examine the patient. You see, is there symmetry between the left and the right? Is there muscular hypertrophy? You palpate for presence of tenderness or spasm. You feel that the muscular area is tensed. Physical examination continues. We have evaluation of temporomandibular joint. As we've said, tenderness, clicking, crepitus. Then you can also measure the range of movement. Patient should protrude, should retrude. You see if the jaw is deviated as the patient is trying to open the mouth. Then radiographs may be necessary. When we take panoramic X-ray, this shows the jaw, the left and the right side of the jaw. Then you'll be able to view the bone, you'll be able to view the mandibular conda and the glenoid fossa. Then tomograph, this one shows, the tomographs show details and they occur in slices. TMD arthrography, this is injecting a contrast medium, and this will help us to evaluate the joint space. We'll be able to know the position and the morphology of articular discs. Is there any adhesion? Is there any perforation of the discs? And we can see the clicker, the diagram down, or we do a CT, combination of tomographic view computer. In this one, we'll be able to analyze both the hard and the soft tissue, but it's better with the hard tissue computed tomograph. Or an MRI, most effective in soft tissue analysis. Excellent image of intra-articular soft tissue, the intra-articular disc, excellent. Nuclear imaging, we have technetium 99 is an isotope of technetium, and it's concentrated in the area of bone metabolism. Or we can have SPECT, single photon emission computed tomography, which is also very good in determining bone metabolism. But this SPECT is very sensitive and difficult to interpret in someone that is not trained. Transcranial radiograph, excellent evaluation of lateral pole of the conda. Then we can do blood or the blood chemistry. Calcium, bone, phosphate or alkaline phosphatase. Raised ESR, for instance, in SLE, and positive rheumatoid factor. Serum uric level, gouty arthritis in degenerative condition. Serum creatinine and creatinine phosphokinase level are indicators of muscle diseases. Treatment. We have to first of all educate the patient, tell the patient the condition the patient has. We can do a physical therapy, splinting, arthrosynthesis, Botox injection, and the last resort is the surgical, which could be an arthroscopy or open surgery. Treatment continues. Initial treatment is frequently a non-surgical procedure. We counsel the patient that are undergoing stress. We may call behavioral medicine to assist. We can educate the patient and tell them the pathogenesis of the condition. They will be able to help themselves and describe. They will do lifestyle modification. People that chew gum, we can tell them to stop chewing, and people with habits, we fabricate an appliance. At home therapy, they use e-therapy, then sometimes to physio for trans-electric nerve stimulation. Medication continues. We can give anti-inflammatory drugs such as ibuprofen 400 mg TDS for about 5 days to 1 week, naproxen, celecoxib, which is Celebrex. We can also give muscle relaxant like lorazepam or diazepam. Tricyclic antidepressant can be given to those that are undergoing psychological issues, psychological problems. Amitriptyline 12.5 mg, 25 mg for 2 weeks. Low dose is usually used in chronic pain. The function of amitriptyline is to prevent the reuptake of amine neurotransmitters such as serotonin and norepinephrine, causing an inhibition of pain transmission. As a result, the patient does not feel pain, and it is effective in decreasing nocturnal bruises. Physical therapy. Relaxation technique can be carried. You can put a spray, and when the spray is used, the muscles are stretched. Then you can now maneuver and in different range of motion. There could be transcutaneous electronic nerve stimulation, but to be applied or be used that method at the physiotherapy clinic. Splint. This is a picture of splint. It helps in reducing the force directed to the temporomandibular area. Design, sometimes it can be a complete splint, full arch, and sometimes it may just be one arch related, and usually one for 24 hours a day for several months. Surgical options. Lavage of the joint. Lysis of fibro joint adhesion. Disc repositioning, can do disc repositioning, or condylectomy, or even condylectomy, and with bone graft. Angioplasty for ankylosing. Antrocentesis. Place a needle in the superior joint space, and you can inject a local anesthetic agent or inject steroid, or even a combination of both. The distension under pressure can now relieve any joint adhesion, and commonly used in patients with anterior disc displacement without reduction. When the disc displacement occurs, negative pressure may be developed within the joint, causing a suction cup effect between discs, the articular disc, and the glenoid fossa. Arthroscopy. Scopy, just to look. In this one, you observe the joint. More sophisticated arthroscopy operative techniques have been developed, and you can now lyse the artery, or we can do open surgery. 5 surgical approaches are known. We have the pre-auricular. You can see from the diagram. We have endoral. We have post-auricular, hemicoronal, and submandibular. The rhythm incision is shown in the diagram. Disc repositioning surgery. Anterior disc displacement failure from non-surgical treatment. That is when non-surgical procedure has been used, non-surgical procedures have been used and with no effect. Then you can do a surgical procedure, and it involves removing wedge of tissue from the posterior attachment of disc, and then you now suture back to the correct position. Severe disc damage is also an indication. Disc repair or patch procedure by dermal graft or facial tissue. Disc removal with replacement. Sometimes you may have to remove the disc and put a replacement. It could be an autogenous graft from the person. It could be temporalis fascial graft that is used. It could even be auricular cartilage, that means from the ear region, and it could be a silastic material. That is an artificial material. And in failure, we have implant fragmentation, synovitis, and gross erosion phases. Arthroplasty for ankylosis. Arthroplasty is a surgical procedure to restore the function of a joint by using a prosthesis. And we have an absolute indication, which can be intracapsular ankylosis. That means within. We now use for this one the separate condyle and the head of the condyle from the fossa. Then it's now recontoured. The condylar surgery include condyloplasty, condylotomy. Total joint replacement, we just replace the joint totally. Sternoclavicular graft, costochondral graft, these are the areas we can harvest the graft. Prosthetic replacement. In conclusion, pain and dysfunction associated with temporomandibular joint and its musculature can be a very challenging problem for the physician. So the physician has to be very knowledgeable, because sometimes this pain could be frustrating, especially in patients that have anatomic. You can see that there is a problem with it, a physical problem. A good history and a careful examination of the temporomandibular joint and its surrounding structures is very, very important. Joint sounds, appropriate radiographs, imaging, and other investigations are important for diagnosing and in the management of temporomandibular disorders. Temporomandibular disorders, in what we've done now, we can have different fields. In temporomandibular dysfunction syndrome can be handled by the oral medicine physicians. They can even start with the arthritis, but later the oral surgeon can be called into play to come and take over when it comes to dislocation, when it comes to or when it comes to fracture. They can now come over. I'm very sure you've enjoyed today's lesson and you really understand the lecture. You go back and read it and also develop more, and you will know at the end that it's a topic that it is important for every dentist, especially the oral medicine specialist and the oral surgeon, to know. Thank you.